good morning. My name is Dele Ogunseyitan. I'm Chair of Public Health here, and welcome to our seminar series. We have to kind of get going, so typically we do a little bit of chit-chatting before, but today our speaker has to leave for Los Angeles right after, so we will proceed. But I wanted to do something a little differently this morning before I introduce the speaker. I got a voice message on my phone last week, Friday, and I wanted to play it to you because it kind of exemplifies why we open up this seminar series to the community. And if whoever left this message, if they're in the audience, please.
Welcome to Community. Please enter your mailbox number.
Okay.
Please enter your passcode. You have one saved voicemail messages. To review your messages, press 1. First saved message received 3:24 p.m. Friday from voicemail.
Oh yes, I read in the newspaper that UCLA is mandating their students to get vaccinated for the measles, mumps, rubella, etc. Why doesn't the school mandate flu vaccinations? Because the flu is one of the deadliest diseases we have in America. Tens of thousands of Americans die of the flu every year. And yet someone can come to school and have the flu and infect other students, and none of you do anything about it. But boy, you just love those measles, mumps, and rubella vaccines for some reason. When you folks have stock and Merck or something, is that the reason? You know? I mean, it's just absolutely, I don't even feel like I'm living in America anymore. I feel like I'm living in the old Soviet Union. People are forced to inject foreign substances into their body against their will as a condition of going to school. But you can go to work with.
End of message.
Okay. I was thinking, oh, I will reply and be nice to this person, but anyway, it shows why we have to educate the community, engage in dialogue about health risks, not only in the United States, but also worldwide. And some of the risks that we think have been banished from the US tend to creep back. And I just learned that Europe is also facing similar problems with measles. So, global health, interestingly, it's used to be something out there, but we imported this case of measles that became essentially a national outbreak. Today's speaker has been all over the world practicing global health, teaching and conducting research. Dr. Klausner is a professor of medicine in the Division of Infectious Diseases and the program in global health at UCLA. He earned his medical degree from Cornell and did his residency at NYU Bellevue Hospital Center. He also earned his MPH in International Health and Epidemiology at Harvard School of Public Health. Then he worked at the Center for Disease Control and Prevention in the Epidemic Intelligence Service Officer, as an Epidemic Intelligence Service Officer. And he's worked as a Deputy Health Officer for San Francisco Department of Public Health, and also the branch chief for HIV and Tuberculosis at the CDC in Pretoria, South Africa. He's really interested in the use of information, digital and algorithmic technologies to facilitate the access to treatment for disadvantaged populations. Today he's going to talk to us, essentially take us through an excursion through his recent and most engaging experiences. He just returned from Peru, for example, and we're very lucky to be able to squeeze in the time today with him. So please help me welcome Dr. Klausner.
Okay, Can people hear me? All right, thank you very much. So at first I wasn't sure if that message was positive about the MMR vaccine, or they were talking about why we don't have stricter vaccine requirements for the flu. But anyway, it's a big debate, and it's actually wonderful that people are debating the importance of. Actually, it's not wonderful. They're debating, because it is there's only one real answer, that we definitely need to increase vaccination. But it's wonderful that there's awareness about the importance of vaccination, and perhaps there'll be new policies which will make it more routine and easier for people to routinely get vaccinated. So what I thought I'd do is actually kind of take you through a tour of some of my different research projects around the world and highlight some different advances in our response to infectious diseases globally. In terms of transparency, I'm a faculty member at UCLA. I am a guest researcher at the CDC Mycotics or Fungal Diseases Branch. I'm a board member of a nonprofit called Youth Technology and Health, or YTH, advisor to HealthVana. So that's my interest in technology and online and social media interventions around health. Consultant for AIDS Healthcare Foundation, and I do work with different manufacturers and national organizations for research. So about 2 weeks ago, the former administrator of USAID came to speak at UCLA and talked about the different kind of core policies, and really highlighted 7 areas. And I was struck by how he recognized how interdigitated these areas were. That really, you could not have increased food security without global health. You needed a healthy workforce, but in order to move food around in certain countries, you had to obviously have a sustainable economy, and had to have infrastructure, you had to have power, and you need to have security and a stable political system. And I think it kind of reflected to me the new insights that these people are having, how connected all these different aspects are in terms of development. And while most of us work in specific areas and often in silos, in order to really advance the kind of social benefits and health benefits of mankind, we do need to work more closely with others in other fields. And that's one thing that attracted me to leaving government and public health and moving into academics, was the idea that I could work with different schools, different disciplines, and really be more multidisciplinary in my work. When we look at the global burden of a disease by cause and disability-adjusted life years, so DALY's disability-adjusted life years, as many people know, is a metric that enables us to capture kind of the impact of diseases starting from infancy to old age. So mortality is often what people look at, but mortality, an infant who dies would be counted the same as a person who's 75 who dies in terms of death rates. But when we look at adjusted life years, it weighs the impact of death on an infant would be much greater than the impact of death. And when you look at this, you can see that non-communicable diseases globally, heart disease, strokes are the principal cause of disability-adjusted life year lost, but communicable diseases are important second, and then injury, homicide, and violence important third. And so my training and my response over the past 25 years has been focused on infectious diseases. So one of the most common infectious diseases worldwide is tuberculosis. 1 out of 3 humans on planet Earth are infected with TB. And every time I say that to non-medical audiences, public health audience, people are shocked that 1 out of 3 people have TB. And we've seen it cause substantial amount of morbidity and death with the overlying epidemics of HIV, incarceration, social disruption in parts of Russia, and poverty. And this is the kind of conventional way physicians think about tuberculosis, that people are exposed. It's airborne through respiratory droplets. About 90% of people infected won't develop any symptoms or any disease. 10% over their lifetime will, and they'll develop active TB. And our control strategies have been focused on reducing exposure and reducing the rate of infection going to active TB. When we look at the factors that are related to development of active TB, you can see AIDS, and that's why the map of Africa now has the highest burden of TB disease in the world, because AIDS is such a profound risk factor for people developing active TB. We've also learned it's not just the immunosuppression of AIDS, but it's people with HIV going to the medical care setting and people being hospitalized and being exposed and re-exposed on a regular basis. Silicosis, or gold miner's lung, from digging into the hard rock to do mining, also very strongly associated with development of active TB. So in a place like South Africa, you have this quadruple epidemic of HIV, TB, and silicosis, and then early mortality. Immune suppression, so now in the United States in particular, people are on long-term immunosuppressive therapy for rheumatological conditions. I work in the hospital, Ronald Reagan Medical Center. People are treated with biologics for different conditions. That's where we're seeing a lot more new TB. But people are starting to recognize diabetes, which now is kind of much more common globally, has a lower risk factor, but being more common actually has a much greater attributable risk. So diabetes is emerging as much more important than a lot of these other high impact conditions, but because it's more common, has a greater influence on development of active TB. And as people are starting to understand the pathogenesis TB, and particularly with new modalities such as PET scans, which is a type of CT scan or CAT scan, we actually look at areas of inflammation, active inflammation that are ongoing in the body. We're learning a lot that different parts of the lung tissue can have different areas of active infection versus quiescent infection, different response to treatment, and it's a lot more complex than what we previously thought. And Dr. Lin has come up with a new paradigm of TB. Instead of that one I showed you earlier where people are exposed, infected, they go to latent or they go to active, there's actually this spectrum. And when I was working in Johannesburg in the major hospital there from about 2009 to 2012, we're seeing people come in with fever, low blood pressure, and essentially sepsis. And in my clinical experience, sepsis was usually associated with a bacterial infection like pneumococcus or E. coli, but in this setting it was actually TB. So people were septic with active TB, and TB could be easily cultivated from their blood. Mammillary TB or disseminated TB to other organs, as opposed to just pulmonary TB, low-grade TB, and people seem to go back and forth between active and low-grade and quiescent TB, and that can happen in different parts of the lung tissue. But so by studying TB in humans with a little bit better tests and better diagnostics, we get different insights into the pathogenesis of the organism. One key aspect of control that we implemented while I was in South Africa was trying to get patients at risk, particularly HIV-infected patients, on isoniazid prophylaxis. And isoniazid prophylaxis has been shown to reduce the development of active TB while people are on the drug. And part of PEPFAR's approach to controlling the TB epidemic in South Africa was to help support the South African government, put every HIV-infected patient on isoniazid preventive therapy. So when we did this survey in 2011, we found that about 46% of patients were on isoniazid prophylaxis, which actually was fairly high. Considering it was a relatively new program. And a lot of my work in South Africa was to ensure implementation of WHO guidelines, implementation of PEPFAR recommendations, and we would do that through evaluations and surveys like this. And Joel Shahab was actually a Alan Rosenfeld Fellow, so he had gotten his MPH already, and Alan Rosenfeld was a former head of global and reproductive health at Columbia University, passed away. They named the Alan Rosenfeld Fellowship after him, and the CDC has a 2-year fellowship program for people interested in global health, and Joel Shahab did this as part of his work with me over in South Africa. So another fellow of mine, Sang-Hook Shin, we've been looking at mixed TB infections. So one of the challenges with TB treatment is not everyone responds to treatment, and people aren't all cured from standard therapy. And one thing we've learned by looking at the genetics of the TB infection, by looking at the culture isolates and then sequencing the TB we get from the positive cultures, is that people are actually having multiple simultaneous infections with different TB subtypes and different organisms. And this chart shows you that in HIV-infected patients, particularly those who are immunosuppressed, so at a CD4 count of less than 100, which would be consistent with advanced AIDS, there was a high prevalence. Between 20 and 40% of those cases had more than one strain of TB infection. And if they had been treated in the past, about 40% or 2 out of 5 patients had multiple infections. So that suggests people are being continually exposed, and we should no longer think about TB as infected with a single strain, and that has implications particularly in drug-resistant areas where people may be infected with a susceptible strain and a drug-resistant strain or extremely drug-resistant strain in terms of what the best treatment is. So based on these epidemiologic data, then we're developing clinical trials to see what the best way is to treat people with these multi-strain infections. So I'm going to stop there on TB and move into another important infectious disease, particularly in sub-Saharan Africa, is this fungal infection, cryptococcal meningitis. And Cryptococcus neoformis, the most common cause of cryptococcal meningitis, it's a soil-borne organism. It lives in the soil. As the soil is disrupted or people manipulate the soil, they inhale the organism. You get a pulmonary or lung infection. People may or may not have symptoms of that, and then the body, the immune system usually clears it. However, people with AIDS that are immunosuppressed, they get reactivation of this infection, the organism is in the bloodstream, it spreads to the brain to develop meningitis, and unfortunately the most common outcome is death. That treatment requires intravenous amphotericin therapy, which is expensive, it's toxic, it's hard to manage, and not routinely available. When my colleagues did a study looking at the global burden of HIV-related cryptococcal meningitis, you can see that there's over 1 million new cases per year and about over 600,000 deaths. And actually, the number of cryptococcal-related deaths in sub-Saharan Africa is greater than the number of TB-related deaths, because generally TB is treatable, but cryptococcal meningitis is not treatable. So while TB is more common, more people die from cryptococcal meningitis. And it's an unappreciated, important infectious disease in Africa. So there's been some new technology, and you heard I was interested in technology and how we can apply new diagnostics, particularly to help control adverse outcomes of infections. So this is a new dipstick called the lateral flow assay. It's basically a little test strip that goes into a specimen which can have blood in it, it can have cerebrospinal fluid in it, and then within 10 minutes you get immediate test result to know, 1, control if your test worked, and 2, what the result of your test is. It's highly accurate, and it's very affordable. And so the idea was, okay, how can we use this technology to try to address this epidemic of cryptococcal meningitis and reduce cryptococcal-related deaths? And about 10 years ago or more, researchers published that the cryptococcal antigen could actually be detected prior to people being symptomatic. And this was really not well known or appreciated. So you can have actual cryptococcal antigen in the blood that could be detected before someone developed meningitis. And historically, there's no easy way to detect that antigen. You had to do culture, you had to do latex agglutination tests, which were somewhat laborious or expensive or not routinely available. So our idea was, well, now with this dipstick test, could we just get a blood specimen, check the blood specimen, and then see if people had the infection in their blood, and then treat them before they develop meningitis. And that became the CDC's plan in about 2010, if we could scale this up and implement this screening treatment program to prevent meningitis in South Africa and then roll it out regionally. This is the kind of information, educational materials that we made for patients, basically to explain that crypto or Cryptococcus is a germ. It can affect the brain, cause fever, headache, nausea, neck pain. How people get it, they get it from inhaling it, not necessarily person-to-person spread. And then you can get a blood test and see if you have the cryptococcal germ to get treated before you develop severe symptoms. So we looked at different screening approaches, and one was looking at the approach in sub-Saharan Africa. We found that when we screened AIDS patients with a CD4 count of less than 100, about 5% had a positive test. And those 5% would have otherwise gone undetected and probably developed cryptococcal meningitis and died. But by treating them early with fluconazole, which is an oral medication, pill to take by mouth, you can actually abort that infection. We're able to show that, and others have shown that subsequently. But also I was curious in terms of what was happening with cryptococcal antigen in the United States. So we did a large look-back study, looked at over 25 years of specimens collected in the Women's Health Study and the MACS, the Multi-AIDS Center Cohort Study. So they have specimen banks at the NIH. And basically, I just called up the NIH. I said, I'd like to do this study on the preserved specimens. They said, send us a concept, send us a protocol. About a year later, they released the specimens to me. I worked with a laboratory to test the specimens, and we're able to demonstrate that in the United States, among AIDS patients, there was about a 2% positivity of cryptococcal antigen. And importantly, we were able to show that there was a strong association with survival, that patients who were asymptomatic, these are asymptomatic patients, so they don't have meningitis yet, they just have the antigen in their blood, were much more likely to have a shorter survival than those who were negative. So this was actually one of the first studies that showed the difference in survival just in this cohort based on the antigen status, and we're advocating now to update the recommendations for AIDS patients and screening for Cryptococcus in the United States as well. In 2011, the WHO had already recommended that, but the US recommendations did not routinely include screening. And this is kind of an example of research I like to do using epidemiology to develop evidence to change practice and policy. So a lot of my work is translating evidence into practice or translating evidence into policy. So as a health official for 16 years, I kind of have a unique vantage point to think about how health officials and policymakers use data, and then how you take those data, so those data are just not published in a journal, but then can be used to advocate for the changes in practice or changes in policy. Now I'm going to move from Cryptococcus to Neisseria gonorrhea. So gonorrhea is a sexually transmitted disease, and one of the big problems with gonorrhea is the organism is particularly promiscuous in terms of its ability to integrate local DNA in its environment. A lot of bacteria, you have to stimulate it to have local DNA from other organisms enter it, but gonorrhea on its own seems to pick it up, and part of that results in a lot of resistance. And historically, gonorrhea was resistant to the early sulfa drugs in the 1930s, eventually penicillin from the 1940s and 50s, tetracyclines in the 1960s, and then ciprofloxacin in the 1980s and 90s. And now, one of our last and only effective drugs against gonorrhea is called cefixime, or in the injectable form, it's called ceftriaxone. And you can see this chart shows a creeping in the increased resistance or decreased susceptibility or elevation of MIC. The MIC stands for minimum inhibitory concentration. So that's how much drug you need to have to inhibit or stop the organism from replicating. And you can see the percentages start to go up. First in men who have sex with men, Western states, California, Oregon, and Washington, and then there seems to be a little bit of creep elsewhere. So this is particularly concerning for health officials and for physicians because we would potentially lose our last line of antibiotic to treat gonorrhea, which would mean people would have to be treated in the hospital with intravenous medications. They may have to be treated with multiple antibiotics, and it may, become a truly superbug that's completely untreatable. So when the CDC recognized this, what they did was sound the alarm. And this is the way the CDC sounds an alarm. They write an editorial in the New England Journal that says, it is time to sound the alarm. So now the alarm has been sounded, and it gets picked up by the media, by Ynet, it gets picked up by Wired magazine because a lot of technology people might be interested in this. But it's really not going to have any effect until it gets picked up by business women in Forbes Women magazine. So now people who really matter, can make a difference in policy, can be made aware of this of this threat. And now when I started to think about resistance, it seemed to me maybe we should flip it and think about susceptibility. So when you look at the 2012 data for gonorrhea in the United States, you can see that 66% or 2/3 of the organisms are susceptible to everything. So we could use penicillin, we could use tetracyclines, and if you look at the little subdivisions and you add it up and do the math, about 85% are susceptible to ciprofloxacin, which is a very safe, easy to use, single dose medication by mouth. So I thought, is there a way that we could give the results to clinicians that they could then treat on the basis of susceptibility? Now, one of the problems is that gonorrhea is no longer diagnosed by culture. It's diagnosed by a molecular assay or a DNA or an RNA test. So we don't grow the organism anymore. We just detect it using PCR. And detecting it by PCR potentially prohibits our ability to know if it's resistant or not. We know the way that the ciprofloxacin resistance happens. Ciprofloxacin, the way it works, it binds to an enzyme called gyrase, and that inhibits the action of that enzyme, and then the organism cannot reproduce. When the resistance develops, the gyrase mutates, and then ciprofloxacin can no longer bind to that, and it bounces off essentially. So it's a drug that's no longer effective. And that occurs by only one single point mutation in the gyrase enzyme. On your right, you see a typical antimicrobial susceptibility plate called the Kirby-Bauer. So if something is resistant, the organism grows right up to the disc, which has antibiotics. If it's susceptible, the organism will stop growing around that antibiotic. So I thought we could develop a molecular assay to look at that gene sequence for that gyrase enzyme and then see how that correlated with the traditional antimicrobial susceptibility. So with my colleagues at the San Francisco Department of Public Health at the time at the microbiology lab, we were able to use real-time PCR and create an assay that could pretty readily distinguish between resistant gonorrhea for ciprofloxacin and susceptible. So that was step one, and then we had to compare that to the traditional microbiology data, and actually it compared incredibly well. So we had 100% sensitivity for identifying susceptibility and about a 98% specificity. So we were able to discriminate very well between resistant and susceptible types of the organism. So then the idea is, based on this test, we can do what I call molecular-based resistance testing. We can rapidly detect serial gonorrhea based on traditional methods. And in that same test, that PCR or amplification test, we can also detect the antimicrobial resistant profile. We can then give this back to clinicians to to use for treatment. We can broaden the types of antibiotics that are used for treatment of gonorrhea, and that would reduce selection pressure and potentially decrease the emergence of resistance. This idea was recently funded under an NIH R21 award, and we'll be implementing this at UCLA probably in April, and that every new gonorrhea test will undergo this resistance test, and we'll be able to observe how people change their prescribing practices. So moving to another area, it was known 65 plus years ago that infection in the female reproductive tract, especially in the cervix, can cause premature rupture of membranes and induce premature labor. This process is responsible for many preventable infant deaths. So right now, as the world is embarking on a revised Millennium Development Goals, one of the pillars is to reduce under 5 mortality. And actually, if you look at what's the #1 cause of under 5 mortality, it's prematurity. So babies are born prematurely, high risk for infant death, pediatric death, and bad outcomes. And if you look at what the causes of prematurity, one of them is infections during pregnancy. And this was known for 65 years, but really no one's doing much about it internationally. There is a WHO initiative that's been around since 2007 now to eliminate congenital syphilis. So syphilis is recognized as one of the important curable infections of pregnancy. And the targets set for this year were that all pregnant women should be screened for syphilis, and those, or 95% of those, should be treated. Most people are not aware what congenital syphilis is. People think about it more clinically or sometimes associated with stillbirth, but it can cause a variety of adverse pregnancy outcomes: miscarriage, prematurity, stillbirth, low birth weight, clinical syphilis in a newborn. This is actually a case of a pregnant woman who was treated with azithromycin in China, but the drug azithromycin or erythromycin does not get through the placenta too well. It's a large molecule, so the baby essentially received no therapy. So this is a case of treatment failure of a baby born with congenital syphilis. But congenital syphilis globally is actually, syphilis in mothers is more common than HIV in mothers. Syphilis in mothers is more common than HIV in mothers. And you say, well, how can that be true? All I hear is about HIV in mothers and mother-child transmission of HIV, but syphilis is more common in places like India, Indonesia, Philippines, China. So large burden populations have more syphilis than they do HIV. So globally, syphilis is more common, and adverse outcomes due to syphilis in pregnancy are more common than HIV in pregnancy. We also know that syphilis increases the rate of HIV transmission. So a mother with syphilis and HIV is 2 to 3 times more likely to transmit HIV to the newborn than a mother with HIV and without syphilis. So thinking about those different things, about how common maternal syphilis is, the importance of HIV, we wanted to twin and bring those 2 programs together and actually do a dual elimination strategy of both HIV and syphilis. And again, technology. And when things come together, in my mind, from policy to improving health outcomes, and there's technological advances, I like to take advantage of those and jump on those. So these are new diagnostic tests. They're called dual tests or multiplex tests. So with the same drop of blood, with the single device, can test both for HIV and syphilis. So what better way to make sure that every pregnant woman gets tested for HIV and syphilis than have a dual test? And when we looked at what was happening at a case country like Malawi, we found 90+% of women were being tested for HIV, but only 12% were being tested for syphilis. And that's because there are different procurement strategies, different resources, different attention to the problems. But now, through the introduction of these dual tests, there's really no reason that a mother should be screened for one and not the other. So this technology enables us to potentially achieve better health outcomes. And part of my research group, and this is a study from our group in Peru, is to evaluate these not only in the laboratory but in the field. And this is just a recent report on how these laboratory tests, these dual tests, compare to standard single tests, and actually they performed equally or not better. They are preferred by patients, by providers, and actually they're more cost effective than doing separate tests. So this feeds into what I briefly mentioned, this WHO dual elimination strategy. And WHO has recognized that we can eliminate actually both mother-to-child transmission of HIV and syphilis. So they're starting to twin the program. And on your left was a editorial I'd written in the WHO bulletin about missing opportunities to save lives at birth. There was a lot of resources and efforts putting on HIV, but we're missing other curable, easy to diagnose and treat infections like syphilis. And then extending that a little bit, we just started recently looking at other curable infections in pregnancy like chlamydia and gonorrhea. So from a large NIH trial looking at different ways to prevent mother-child transmission of HIV, in these over 1,000 women from 4 countries, South Africa, Brazil, Argentina, United States, they had stored urine specimens. So similarly, that story of going to the NIH and asking them, well, what about those blood specimens you have in storage? I went to the NIH and said, what about these urine specimens you have in storage? Can we test those and look for other outcomes? And NIH in general, once they've done these studies, they're really happy for people to approach them with new study ideas. It's a little bit of a process and bureaucracy to get through the administration and concepts, but you already have a data set, you have a well-characterized study. It's a nice opportunity for low cost but potentially important epidemiologic work to be done. So when we looked at the urine from these over 1,000 women, we found that 20% had chlamydia. So 20% of pregnant women in these 4 different countries had chlamydia, about 5% had gonorrhea, and we looked at HIV transmission rates, about 8% of all transmitted, and then we looked at what the relationship was between chlamydia, gonorrhea, and HIV transmission, and as you can see, women who were duly infected with both chlamydia or gonorrhea had about a 22 or 23% transmission rate versus about 7% overall. So about a 2.5-fold increase in transmission rate if they have these other curable infections. So similar to syphilis, if we could screen and treat and cure these infections, we can have better impacts on HIV transmission and perhaps ultimately on prematurity. So as I was starting to develop these data around HIV, because I really came from 20 plus years of being very HIV focused on HIV prevention, I wanted to take a step back a little bit and say, okay, well, can we also improve other pregnancy outcomes other than HIV? And I mentioned that preterm birth is a major problem globally. What this table shows you is the rates of preterm birth estimated by WHO. In Malawi, they're 18 per 100. So more than 1 out of 6 pregnancies in Malawi result in a preterm birth. And that goes down to about 14 per 100 in Haiti, to about 13 per 100 in Costa Rica. So, you know, it's not necessarily only the low-income countries, but there are middle-income countries and upper-middle-income countries that also have high rates of preterm birth. And in the literature, there's been some recent studies showing, again, the association between these STDs in pregnancy like chlamydia and adverse outcomes like preterm labor. So in this meta-analysis, which was done by a Brazilian group and published in the Brazilian Infectious Disease Journal, you can see that there was a summary risk of 1.35 for the association between chlamydia and preterm labor. And then for the students in the audience, if you take out your EPI calculators, you can calculate the attributable risk due to chlamydia infection and preterm labor. And it basically comes out to 26%. So potentially 26% of preterm labor in these settings could be attributable to chlamydia infection. So if you had an intervention that could reduce 1/4 of cases in preterm labor, you'd be really excited and trying to implement and intervene in that process. So we've started this process. In the United States and a few other countries, it is routine to screen, but in most countries it is not. And in Peru, it is not. And so we looked at 2 large urban hospitals in Peru, Institut Nacional Materno and the Loaiza Hospital, pretty typical large public hospitals in the setting, do tens of thousands of deliveries every year. We approached about 646 women over a 2-month period. We enrolled 603 women, so 94% accepted to be screened for chlamydia infection. The few reasons for refusal were no time, they're afraid of the test, or they were a minor who were unaccompanied by an adult. And then in terms of the rates of infection, we found 10% had chlamydia, 0.3% had HIV, low percent had syphilis, but 1 out of 10 women had chlamydia and no idea. Did not know they had chlamydia infection, never been screened for chlamydia before. And this, again, a curable infection associated with adverse birth outcomes. We were able to show that we had very high treatment, so 98% of women were treated. They all had tested cures. All those who were treated, we were able to document 100% tested cure. And then importantly, with any sexually transmitted infection, it's important to make sure the partners are treated. So we offered different ways to get partners treated. The majority accepted extra medication to bring home to their male partners. Some brought their partners in for what we call concomitant directly observed therapy, so both people were treated at the same time. A few had no partners, and a few did not want treatment for their partner. So based on those data, then the idea is to do another trial to see, okay, if we screen and treat in this group, can we reduce prematurity or adverse pregnancy outcomes versus a comparison group? And ethically, it's a little bit challenging because the United States is standard of care. So when this was proposed to NIH, probably May 2014, so about a year ago almost, they said, no, this is not ethically tenable. You can't randomly assign people to screening treatment, which is standard of care in the United States, and just watch another group. So we're coming back with different trial methods to see what's acceptable. And it's, interesting because unless we do the research, we can't convince policymakers to make the investments. And we can't do the research because it's considered not ethical to do in that setting in that way. That's for your ethics class to continue to debate on. So now I want to move to another infectious disease. So this is a dark field microscope. So if a patient came in and they had a lesion, and you swab the lesion, and you put the swab on a slide, and you had a special microscope which refracted the light in a certain way, and you had a black hood in a dark room, this is what you might see. And these organisms are the organisms of syphilis or Treponema pallidum or bacterial spirochete. So I've been really curious and engaged with syphilis research since I started at the San Francisco STD Clinic in 1995, and it's always been an area that's been quite intriguing to me. Syphilis, as people know, has become much less common in the United States overall since the advent of penicillin in 1943. Very strong control programs, mandatory testing before marriage. It's actually, I learned in Peru, it's required to get a syphilis test before marriage there as well. But there's no more mandatory testing programs in the United States. But because of those programs, people are identified and treated. And that's the basis of infectious disease control, case finding, and if it's curable, treatment. So cases come down dramatically. There was a small blip in some urban areas in the United States related to the crack cocaine epidemic, people theorize. And then you can see it came down, and then a slight increase. But you blow up the increase, it's really been exclusively in one group, men who have sex with men, particularly HIV-infected men who have sex with men. So as we've become better at controlling HIV through HIV treatment, we've become less effective at controlling other STDs. Now we're doing more screening, more early detection, but we still see higher rates of syphilis in particular in sexually active men who have sex with men in the United States, and this is reflected globally. So in most European capitals and in Australia, we also see some substantial increases. So I'm trying to understand a little bit better about the infection and how to treat it and how it's spread and control. We set up a molecular laboratory in Peru where we can collect blood specimens from patients newly diagnosed with syphilis. We can extract DNA from the blood specimens, and then we can do typing, and we can characterize the different circulating types. And no one's ever looked at the different aspects of molecular biology of syphilis in Peru or in South America. So we're hoping that will inform us about, are there any networks of transmission that we're missing or not being adequately identified? Are there any specific associations with any subtypes and clinical manifestations or with treatment failure? So this is part of an NIH project that's looking at technology transfer to be able to enhance the capacity of the research institutions in Peru to be able to do more advanced level epidemiologic analysis. And then also as part of this project, we're looking at cytokines. And on this chart on the bottom, there's 56 different cytokines, different interleukins, tumor necrosis factor alpha, different cell markers that are associated with the immune system and immune system response. The blue is a control. The red is patients with syphilis, and the green is patients without syphilis. And you can see largely they track similarly, but there are some important differences in some places between the patients with syphilis and patients without syphilis. And that's going to help us identify a cytokine profile that we can potentially use to enhance the diagnosis of syphilis, or use a cytokine profile to be able to look at treatment response. The syphilis tests we currently use were basically invented in the early 1900s, the Wassermann test. And there's been really no advancement in syphilis diagnostics in over 100 years. So by understanding the immune response to syphilis infection, we're hoping to enhance our diagnosis of syphilis. Now I'm going to just end around HIV. And as I said, I just came back from Peru Saturday. And one thing striking, which was presented at a meeting by my colleague Carlos Caceres in Cape Town in the fall, was the high proportion of men with HIV who don't know it. So in the United States, on average, about 20% of people with HIV don't know it. Among men who have sex with men in the United States, it's about 25%. In some high-risk groups for infection, African American men who have sex with men, it's maybe about 35%. But in Peru, 70% of people with HIV did not know it. And if you think about any effort that's going to rely on case finding, if people don't know they're infected, can't access treatment, can't change their behavior, you're never really going to have any impact on the epidemic. In San Francisco, about 95% of people with HIV know they have it. In London, it's about 80%. In Vancouver, it's above 90%. But 70% not knowing it is quite high. So we need better programs to help people learn their HIV status to make it simpler. So one thing we've been looking at in Los Angeles is this in-home oral HIV test. So right now, any of you can go online, or you can walk into your Walgreens or CVS, and you can plunk down about $40, and you can buy this HIV test, take it home, swab your gum, and within 10 minutes know your HIV test result. No doctor, no nurse, no clinic, just $40 and a walk to a pharmacy to get the test. Now the problem is that those are still barriers. $40, people do not have $40 burning a hole in their pocket to go get an HIV test. There's still denial, there's fear, there's uncertainty about getting tested. So I wanted to see if we can figure out how we can get these tests to people who need them. One way was to put the test in a vending machine in a sex club. So this is the Flex Sex Club in Los Angeles, one of the more popular sex clubs. And this is a HIV self-test vending machine. It's a smart vending machine in terms of you have to put in a PIN or a 4-digit code. It's also internet enabled, so we can monitor the stock, the distribution, the frequency of vends based on the internet information we get. And this was launched in December 1st. I don't have the January data, But in the month of December, 320 tests were vended. And it's a pretty dramatic number. It's the same number of tests they did all year with their on-site public health department supported testing program. Another way we've been looking at, in addition to the vending machines, is giving people vouchers. So this is essentially a coupon. We can hand out these coupons to high-risk groups. We can make electronic versions of these coupons. We can distribute them through the internet on different websites. And then people take the coupon, they go to a Walgreens, and they present the coupon, they get a free HIV test. It doesn't really cost me anything to make the coupon. And then when people redeem the coupon for the test, then I get billed. So I only have to pay for the test that people actually go and collect. And there's a strong association. We've done some follow-up studies, and people who collect the test use the test. And there's been 4 people out of about 100 that we've surveyed who were identified as newly infected, and all 4 of those did seek care and treatment. And that's always been a concern about self-testing, or will people seek care and treatment? At least in our small study, it was 100%. Then a third way would be, okay, well, vending machines, you have the vouchers. Well, how about just buying it online? I mean, my family, we must buy every day. We have new Amazon.com boxes coming in. So it seems to be the most popular way that people are shopping these days. So why not just link them to the website where they can buy it online, and then we can provide them a coupon or a promotion code where there's no cost. So they go online, they put in the code, they put in their address, and about 3 to 5 days later, they get a brown package with the actual test kit. So those were the different ideas, and I want to explore, okay, well, what will people use? What's popular? How will that work? So we designed a small study that was funded by the Center for AIDS Research at UCLA to try to answer that. So what we did, first of all, we had to think, okay, well, where do we promote this? Where do we go? So one of the most popular sites, social media, is a site called Grindr. Right? So it's a social networking application where men who want to find other men to have sex with. It allows geocoding so people can geolocate each other. So we basically advertised on Grindr, and we did a type of advertisement that when someone opens their app for the day, the full app has the ad, and they basically have to get through that advertisement to be able to proceed with the application. So they click on the link, and they go to the UCLA website, and then they're given a choice. Do you want your test to come to you by the mail? Do you want a voucher, or do you want to go to a vending machine? And you can see on the results, so during about a 1-month campaign, we had 11,900 website visitors. That's pretty good for a public health HIV testing promotion campaign. 280 people per day, and we had 344 test requests. So 10 requests a day, and then of those 344 requests, 2/3 wanted it mailed, about 30% wanted vouchers, and about 4% using the vending machine. So the vending machine is in Los Angeles. It's complicated. You have to go there. Not very popular, but having tests sent by mail was actually very popular. Now the question was, are we reaching the high-risk population? So we studied 127 of these 344 test requesters. 2/3 were young men, 18 to 30. 13% were African American. 87% were Hispanic or Latino. I think the inclusion criteria for our survey was you had to be non-white. And a high proportion reported condomless anal sex, and 38% had only tested once, and 10% never tested. So almost half had either never tested or tested only once in the past year, but they were sexually active, having condomless anal sex. And in the survey so far, we found that people are using the test. So another 4% reported testing positive. Both persons got treatment. And now we have a larger application to NIH to see if we can do this on a larger scale. This is pilot data, and now we're turning into hopefully a 5-year trial. So then lastly, talk about one of the oldest interventions. So about 6,000 to 7,000 years old is male circumcision. And you're saying, why infectious disease and male circumcision? Well, HIV obviously is men are circumcised are highly protected against HIV, but there's also other important infections that they are protected against. The global distribution of circumcision, you can see 80% prevalence in predominantly Muslim countries, modest prevalence in high-income countries, and low prevalence in many lower-income Christian countries. How does the foreskin increase the risk of infection, or the lack of foreskin reduce the risk of infection? It's felt there's several different mechanisms. So one is that this part of the foreskin, or the inner foreskin, is a thin mucosal membrane. So it's more like the inside of the cheek, or the membrane that's over the eye, the conjunctiva, or the membrane inside the rectum or near the cervix. And those tissues are highly susceptible to viral infection. The second thing is that the tissue can have small trauma during intercourse, and that can lead to breaks in the immune barrier. And then the third is that the microbiome, or the microbiological environment under the foreskin, is different, and that can support different kind of immunological setting that increases risk for infection. And then lastly, there are target cells in this mucosal tissue. So there's dendritic cells or Langerhans cells that grab pathogens and make it more susceptible if those pathogens are captured by these cells inside the tissue. There's a strong association, ecological association, between HIV prevalence and circumcision. So where circumcision is low, HIV is high, and vice versa. Recently, both the CDC and the American Academy of Pediatrics have reversed about 20 years of silence or kind of equality on the issue, and come out with strong pro-statements that says male circumcision protects against urinary tract infections. So urinary tract infections in newborns, babies, are an important cause of chronic kidney disease and dialysis in some patients. Human papillomavirus, or the HPV, which causes cancer, penile cancer and cervical cancer in females, warts, HIV, herpes simplex, syphilis, penile and cervical cancer, and inflammatory conditions. So there's multiple benefits to circumcision above and beyond just protection against HIV. And because of that, there's been an interest in studying in terms of new devices or old devices. So the standard devices for newborns are shown here. There's a Gomco, there's the Mogen clamp, which is probably the most commonly used for newborns worldwide. A brand new device called the AccuCirc, and then the Plastibell is a standard device used in a lot of US hospitals as well. And then in adults, there's been a big advance with this Prepex device, which is a rubber ring, O-ring, and then a plastic device which kind of crushes the tissue and allows for non-surgical providers, nurses, health officers, clinical officers to use this, and it's been widely used now in the scale-up in Rwanda for adults. And then the Shan ring, which was invented by some Chinese scientists, is also kind of similar. So non-surgical ways to do circumcision. About a month and a half ago now, maybe a month ago, we went down to Haiti. I was at the International AIDS Conference 2 summers ago, and I was introduced to the First Lady of Haiti. And we're talking about different health interventions and what could be done. And at the time, I had circumcision kind of floating in my head. And I said, well, what's your attitude about circumcision? She goes, oh, I've heard it's very beneficial. We'd love to do it, but we don't have the skills. We don't have any trained doctors here. We don't have any resources. And I said, okay, well, if you would allow me to try to help facilitate a training program, you know, would you kind of provide the political backstopping and the will to support that? And she said, absolutely. You know, we'd love to do that. It's just not our highest priority in Haiti right now, but we know it would have long-term benefits for the health of the population. So it took me about a year and a half to mobilize the resources. We had to renovate a building. We had to bring in new equipment and supplies, and I had to find two physicians who routinely did newborn circumcision to leave their practice for a week and travel down with Haiti, and then train the Haitian physicians on how to do it, with the ultimate idea of leaving a permanent training center in Port-au-Prince, Haiti, to train other physicians in the immediate area and then ultimately in the region. So we were able to complete this effort in November 2014. In 2.5 days, we did over we did 103 circumcisions. We did follow-up, 0 complications, and now the circumcision program is ongoing for infants at no cost to parents or their guardians, and they do 3 days of circumcision at the site every week. And now they have training set up for other physicians in the area. So I'm going to probably end, and in summary, I talked about TB, this new paradigm about shifting how we think about TB and the use of INH prophylaxis. Cryptococcus, a nice example of early intervention, screening, and treatment to prevent meningitis and death. Drug-resistant gonorrhea, how there's new technology we can apply using molecular tests. Congenital syphilis, particularly on a policy level, twinning things and bridging and bringing one program alongside another to have greater impact. Preterm birth and STIs, the story is still evolving in that, but that's an exciting area for global health interventions and prevention. Syphilis, HIV testing here in Los Angeles and the Southland, and then lastly, newborn circumcision. So thank you very much, and I think I have a minute or two for questions. Thank you. Or maybe not. We have the 1 o'clocks coming in.
Quick question.
Okay, one question to the convener.
The blip in syphilis that's attributed to drug use, it went down. Do you know what the speculation about?
Yeah, so the question is, there was a blip in syphilis in the United States in the late 80s, early 90s that people attributed to the crack cocaine epidemic, but it went down. And arguably the crack cocaine epidemic has not gone down. And it's still a problem. So we think it does have to do with the implementation of control measures and screening. And syphilis has proven itself to be a disease where if the resources are there for control interventions, you can bring it down at the population level. So if you have screening, if you have treatment assurance, if you have follow-up, if you do your partner notification, it's amenable to a health department response. And one of the challenges right now is the out-of-control epidemic in LA County. There is no health department response. And if you can get people motivated to respond, you can control the spread of infection. So I'm going to stop there, and thank you for your attention.
We have a little
thank you.
cup for you to drink
All right.
from as you travel the world. Thank you. The rest of us will continue the discussion over at the ARB with lunch. Dr. Klausner has to leave for LA right now. Thank you so much.
Thank you.